Hello friends, I am Dr. Farheen and let's do a rapid revision of fetal growth disorders. So let's go through the common terms first. What is a low birth weight baby? When the weight of the baby at the time of birth is less than 2.5 kg irrespective of the gestational age. Which means if the baby is born at 32 weeks or 34 weeks or 30 weeks but the weight of the baby is less than 2.5 kg, we will term it as low birth weight. Alright? Similarly, what is a very low birth weight baby? When the weight is less than 1.5 kg, and extremely low birth weight is when the weight is less than 1 kg. Alright. Now coming to another term. What is a small for gestational age baby? So a baby is said to be small for gestational age when the weight is less than 10 percentile for that gestational age. Now the gestational age is coming into play, and here the baby is less than 10 percentile. So what do we mean by this? It means that the baby is smallest 10 out of 100 babies. Okay, so this is how we plot the chart of the baby, and this is the 90th centile, right? This is 50th and this is the 10th percentile. Okay, now here two scenarios can happen. Alright, so the x-axis is showing a gestational age in weeks and the y-axis is showing the birth weight in grams. Okay, so suppose at 25 weeks if the weight of the baby is 900 grams, alright, over here. At 30 weeks it has become 1100 grams, alright, just suppose. And suppose at 34 weeks it has become 18 grams, okay, over here. So although it is falling less than 10 percentile, the baby is growing and it is parallel to the 10th percentile graph, right? It is parallel. The baby is growing, but here it is less than 10 percentile. So this is a constitutionally small baby. Okay. There can be another scenario in which the birth weight of the baby at 25 weeks is suppose 900 grams. Alright. At 30 weeks it is still 900 grams. Okay, and 34 weeks maybe it has increased just little slightly to maybe 1000 grams. Okay, so the baby is not growing that well, and this is a growth restricted baby, or there is intrauterine growth restriction. Okay, so both constitutionally small baby and FGR baby are below 10 percentile. Both are small, but this is the difference. So let's summarize it. Small for gestational age when the weight is less than 10 percentile, constitutionally small fetus, or there can be a fetal growth restriction also. What is a constitutionally small fetus? The fetus will be healthy, the placenta will be working fine, so the blood flow will be normal and the growth of the baby will be normal, although it is less than the 10th percentile. Alright, what is the difference between FGR and constitutionally small? In FGR baby, the growth is not going to be normal. Why? Because the placenta maybe is not working that well. There is some problem with the spiral arteries, for example, conditions like hypertension, preeclampsia or APLA. There is some maternal condition like some chronic kidney disease, anemia, diabetes, addictions with the mother like smoking, cocaine, or there is some infection at the time of pregnancy which has gone to the baby like Dodge group of infection which is not letting the baby grow that well, or maybe there is some problem, chromosomal anomaly with the baby. Alright. Now within this fetal growth restriction also, what is the pathophysiology? That if there is placental insufficiency, so what is going to happen? There will be limited supply of blood to the baby. So therefore the blood will be redistributed and it will first go to the major organs. Alright. So what are the major organs? Major organs are the heart and the brain. Alright. So therefore the head circumference will be increased. And the rest of the body is not getting so much of blood supply. Okay, so in liver there will be depleted glycogen stores, there will be decreased liver span, and the abdominal circumference will be less. Also the third thing which is going to happen is that kidney is also going to get less blood supply, right? So this will lead to oliguria. And what is this going to lead to? This will lead to oligohydramnios, right? So this is how placental insufficiency is going to manifest as. Now we have, just to summarize, that a small for gestational age baby, right, can be constitutionally small baby, or it can be a fetal growth restricted baby. Talking about the fetally growth restricted baby, there can be further two scenarios, that there can be early onset restriction or there can be late onset restriction. Okay, so if there is early onset IUGR, the baby will be symmetrically small. Alright, all the circumferences will be small. There will be decreased head circumference, there will be decreased abdominal circumference. So therefore the ratio of all of this is going to be normal. Alright, and what is the main cause? Since the baby is getting affected since the very beginning, which means that there is some problem with the baby. So most common cause over here is genetic problem with the baby. Since there is a problem with the baby, so this is going to have a poorer prognosis. Okay, poorer prognosis. Whereas in asymmetrical IUGR, the baby is going to get affected late. Why? Because till 22 weeks the trophoblastic invasion continues, and only after that we are going to see whether the placenta is functioning normally or not. Okay, so it will affect the baby later. So here the head circumference will be high, but the abdominal circumference will be small, right? So therefore it is going to affect the ratios. So the ratios are going to be abnormal here. Alright, and the main cause is what? Main cause is placental insufficiency. Alright, since the cause is placental insufficiency, which can also be treated, so therefore these babies have a good prognosis. Okay, so let's summarize the chart in this. So symmetrical IUGR, the babies are uniformly small, right? And late onset IUGR, the head is larger than the abdomen. What is ponderal index? Ponderal index is the ratio of birth weight to crown rump length whole cube. Okay, so this will be normal in symmetrical IUGR, whereas it will be low in late onset IUGR. Head circumference to abdominal circumference ratio will definitely be elevated, whereas all the ratios are going to be normal in symmetrical IUGR. Alright, so here it is a genetic cause. We have uteroplacental insufficiency in late onset IUGR, and this will have a better prognosis, whereas early onset has a poor prognosis. Alright, so now coming to the diagnosis. How are we going to diagnose fetally growth restricted baby or a small for gestational age baby? So whenever the patients come to us in ANC, we examine them, okay? And from 24 weeks onwards, when 24 weeks of period of gestation, we start measuring the symphysiofundal height. So what is a symphysiofundal height? That we put the tip of the tape over here at the pubic symphysis, and we measure the fundus, the maximum height of the fundus with another hand, and we take the measurement of the uterus, alright, with the tape. Now, this fundal height from 24 weeks onwards of period of gestation is going to correspond in centimeters with the tape, which means if the patient is 24 weeks pregnant, so the tape is going to show 24 centimeter, the height of the uterus, alright. Similarly, at 28 weeks, the height of the uterus should be 28 centimeter, alright. So this is how we measure the symphysiofundal height. Before measuring the symphysiofundal height, there is very important thing, that we ask the patient to pass urine and cum, because that is going to give us a false value. Alright, now what are you going to do when the patient has come to us at 28 weeks, but instead of showing 28 centimeter, it is showing 26 centimeter? What is the next step? So we will offer her ultrasound. Okay, this ultrasound is known as fetal biometry. So this will measure these four basic parameters. So first is the biparietal diameter. It is nothing but the ends of the parietal bone. So this is how it is going to measure the biparietal diameter. The second value is the head circumference. So this entire circumference of the head of the baby will be taken. The third and the most important is the abdominal circumference. Okay, so if they ask question that which is the best ultrasound parameter to diagnose IUGR, it is abdominal circumference. It is the best. Okay, so what they do is that they take a cross section of the abdomen. This is the inferior vena cava, this is the stomach bubble over here, and we take the entire circumference of the abdomen and we measure this. Okay, and the third is the femoral length. So they take the tip of the femur, the distal and the proximal, and they measure the femoral length. So these are the four parameters which are used in the biometry. Okay, now we have diagnosed that symphysiofundal height is not matching in centimeters. We have ordered the biometry, and this is the biometry report which has come to us. So the period of gestation is how much? 30 weeks. Symphysiofundal height was supposed showing 26 weeks. and now your abdominal circumference is also showing 26 weeks. Now what are you going to do? This is definitely a small for gestational age baby, but how are you going to define whether it's a constitutionally small baby or it's a pathologically growth restricted baby? Okay, so after 3 weeks we will repeat the biometry, and let's go through the case 1 now. Okay, so we have repeated the biometry. And what is the gestational age now of the patient? So suppose after 3 weeks period of gestation is 33 weeks. Okay, abdominal circumference is showing 31 weeks, right? So here it was 26 weeks and now it is 31 weeks. So definitely there is growth, right? There is growth in the weight of the baby also, and even the liquor is normal. All right, so what is this? This is a constitutionally small baby. All right. In the second scenario, where the period of gestation now of the patient again is 33 weeks, but abdominal circumference is showing how much? It is showing 29 weeks, right? It was 26 weeks earlier, but now it is 29 weeks still. And there is oligohydramnios. Okay, so oligohydramnios again is a sign of placental insufficiency. All right, so what are we going to do in these patients? Now we will suspect fetal growth restriction and we will order Doppler for these patients. Now before going through the Doppler studies, let's go briefly through the fetal circulation first. All right, so we have the placenta and we know that the deoxygenated blood is carried from the umbilical artery, right? So umbilical artery carries the deoxygenated blood, right? And the umbilical vein carries the oxygenated blood, right? So umbilical vein is carrying the oxygenated blood here, then it meets the portal vein to form the ductus venosus. Alright, so this is the ductus venosus. Now the blood from the ductus venosus again enters the right atrium and goes to the right ventricle, to the lungs, left atrium, left ventricle, aorta, and to the rest of the body. Now there are two differences in the fetal circulation. Okay, first is here the foramen ovale, and second point here is the ductus venosus. So what is foramen ovale? Foramen ovale is a connection between the right atrium and the left atrium. So a part of the blood which is going to the right ventricle, a part of the blood from the right atrium is also going into the left atrium. So therefore there is mixing of blood. Another point where there is mixing of blood is the ductus arteriosus, which is the connection between the aorta and the pulmonary artery over here. Alright, so here also we have mixing of blood, and this mixed blood is going into the aorta and the rest of the body. So generally it is the mixed blood which is circulating. Do not get confused between ductus arteriosus, which is the communication between the pulmonary artery and the aorta, whereas ductus venosus is formed by joining of umbilical vein with the portal vein. Alright, now let's go through a common physiology. Suppose this is a water pipe, alright, and the water is flowing from here outside. We have 3 compartments over here. If there is a block, right, over here, suppose there is a block, so which is the first compartment to get flooded? This will get flooded, right? If the block continues, then the flood is going to enter into the second compartment also, right? This is known as the back pressure theory. So this is the back pressure theory. So suppose if the placenta is not functioning that well, if there is some problem with the spiral arteries, with the uterine arteries, right? So the umbilical artery over here will not be able to carry the deoxygenated blood, right, to the placenta. So the first to get affected is the umbilical artery, followed by what? The second compartment is the ductus venosus, and third is the umbilical vein. So this is the order of affection. So where is the block? The block is in the placenta, right? The block is here. This is the placenta. What is causing the block? The uterine arteries, right? The uterine artery is causing the block. So therefore, uterine artery is always a predictor of fetal growth restriction. It is not going to diagnose the fetal growth restriction. It will always predict that there is some problem with the placenta. So be mindful and monitor this patient, because there can be problems ahead also, and there can be growth restriction. Alright, so uterine artery is a predictor. By what time should the spiral artery trophoblastic invasion get completed? It completes by 18 to 22 weeks. So therefore, if after 22 weeks there is notching of the spiral arteries, right, notching of the uterine artery, it means that there can be IUGR or preeclampsia or hypertension, right, later on in the pregnancy. So the first vessel to get affected as per the blood pressure theory is the umbilical artery, right? Again, to summarize, followed by the ductus venosus and the umbilical vein. Okay, now what is happening, that let's understand the basic concept of Doppler, that at the time of systole, when the heart is contracting, so the blood is flowing through the umbilical arteries into the placenta, the deoxygenated blood. Now when the heart is relaxed at the time of diastole, then also there is some forward flow of blood into the umbilical artery. Okay, this diastolic flow increases as the pregnancy advances normally. Okay, so this is a chart of the normal pregnancy, and we see that this is the peak of systole, blood flow at the time of systole, and this is diastole blood flow, right? So we can see that the graph over here of diastole is increasing, right? So this is what you see in a normal pregnancy. Now if there is a block at the level of the placenta, right, if there is any resistance, so what is going to get affected first? The diastolic flow, right? Because at the time of systole, the heart is going to push at the maximum contraction and some amount of blood is definitely going to flow forward. But what will get affected? The diastolic flow, right? So this was a normal Doppler. Now we will see that the diastolic flow is decreasing. See, here this is a decreased diastolic flow. Here there is no flow at the time of diastole. See, so this is no flow, which is the absent diastolic flow, right? And here what is happening? There is reversal of flow, reverse diastolic flow, and this is very, very bad prognosis, that when the heart is relaxing, then the entire deoxygenated blood is coming back to the heart. Alright, so this is reverse diastolic flow. Similarly, the second vessel to get affected is ductus venosus. We can see that this is systole, this is diastole. Here the diastolic flow is definitely decreased, and again over here there is reverse diastolic flow. The third vessel to get affected is the umbilical vein. So there will be the umbilical veins pulsations, which is manifested like this. Now what is brain sparing effect? So as we have discussed before, that if there is placental insufficiency, so the blood gets redistributed to the major organs of the body, right, to the brain. So what will happen in brain sparing effect is that there will be increased resistance of flow in the umbilical artery, right, but there will be good flow, decreased resistance flow in the middle cerebral artery. So a lot of blood is going to the brain, whereas there is some problem with blood going into the umbilical artery. This is known as the brain sparing effect. Alright, so we can see that diastolic flow over here is increased. Okay, there are few ratios which are used to define IUGR. So the most commonly used is the cerebroplacental ratio. This ratio is calculated by the ultrasound machine itself. So what you need to do is that you just need to look at the number, remember this number. If the CPR ratio is more than 1, it is normal. If it is less than 1, then it is IUGR. Okay, the ratio is MCA PI by umbilical artery PI. PI is nothing but the pulsatility index, and RI is the resistivity index. These are the indexes which are used by the color Doppler machine to calculate how the resistance is through the various arteries. Okay, so just do not get confused. I have given the values over here. You just need to remember that if the CP ratio is more than 1, it is normal. If it is less than 1, it is abnormal. That is it. Alright. Now, this is what we have read at the time of our PG examination. This chart might look daunting to you, but I will make it very simple for you. And since they have been asking complex questions on IUGR, so they can ask questions on this also. Alright. So there are some major risk factors and minor risk factors in the mother, which are the predictors. Okay. So I'm not going to discuss all of it with you. It is there on your screen. So these are the minor risk factors. Generally, it is the maternal age and the parity of the mother and the pregnancy interval. In the major risk factors, again, we have the maternal age, but the various diseases which the mother can have, which can affect the spiral arteries, like chronic renal disease, diabetes, APLA. Okay. One important point over here is PAPA less than 0.4 means of meridian. So what are we going to do? If the patient has one major risk factors, when you are taking the history of the patient and she comes out to have one major risk factor, we will start aspirin in these patients at less than 16 weeks of POG, period of gestation. Okay, we will do the level 2 scan at 20 weeks, and from 26 to 28 weeks onwards we will do their serial scans. Alright, this is when the patient has a major risk factor. If the patient has 3 or more minor risk factors, then we will reassess her at 20 weeks. We will do the level 2 scan, and again we will offer a scan at 20 to 24 weeks, because when does the trophoblastic invasion get completed? Between 18 to 22 weeks, right? So if at 24 week scan there is uterine artery notching, which means that it is a predictor of IUGR, right? As well as hypertension and preeclampsia. So if there is uterine artery notching, what are we going to do? We will follow the same thing. We will serially monitor these patients from 26 to 28 weeks. But if there is no uterine artery notching at 24 weeks over here, if it is normal, then we are not going to do anything. In third trimester, we will assess these patients again. If the patient shows signs of hypertension or preeclampsia or some unexplained bleeding, then we will monitor these patients. So this is nothing. This is the chart which is simplified. Alright. So coming to the management, how did we diagnose these patients? It was basis the symphyso-fundal height measurement, right? After that, what did we offer? We offered biometry. On offering biometry, we got to know that the baby is small for gestational age. So to differentiate between constitutionally small and fetally growth restricted baby, what did we do? We repeated biometry at 3 weeks, right? It confirmed the diagnosis of IUGR. It was confirmed that it is IUGR. What did we offer? We offered Doppler studies. Okay. So this is the umbilical artery Doppler. From here we are going to follow up this patient. Another very important point to note over here is that the time of delivery. Okay, so time of delivery, once you have diagnosed that the patient is IUGR, it is 37 weeks. Okay, just in case if you need to deliver the baby before 37 weeks, if there is some further abnormality and if the baby is less than 34 weeks, then we will offer them steroid and then deliver. Okay, so this is the mainstay of management. Alright, let's go through the chart. So the symphyso-fundal height, less than 10 centile, serial measurements, indicator of FGR. Then we went to the umbilical artery Doppler. Now, umbilical artery Doppler says that it is normal, but we have diagnosed that it's a growth restricted baby. So we will follow this Doppler studies every 15 days. Okay, we will do Doppler studies every 15 days and plan delivery when? At 37 weeks. Alright. Now the Doppler has started showing increased resistance. Now there are various forms of resistance, right? Increased resistance, absent diastolic flow and reverse diastolic flow, right? So here it is just showing increased resistance. So we will follow up these patients weekly with Doppler and twice weekly with biometry. Alright. Why are we following these patients up? Because we want to take the pregnancy as far as we can. Okay. And again we will plan delivery at 37 weeks. But if we see that the baby is not growing for 3 weeks, there is a static growth, or from increased resistance it has become absent Doppler study or reverse Doppler, then we are going to deliver these patients immediately. If the baby is less than 34 weeks, we will give steroid and then wait for 48 hours and then deliver the baby. Alright. So similarly, if there is, we come to know through this monitoring that there is absent or reversal of end diastolic flow, we will plan delivery. If more than 34 weeks, we will go ahead with delivery. If less than 34 weeks, we will give corticosteroids. Alright. So this was all about fetal growth restriction. Thank you so much.